Can you hear me? Can the cable hear me? Okay, yeah. Thank you. All right. Hi, everybody. Good afternoon. Thanks for coming in on such a gorgeous day. It's just beautiful out there. Hopefully, it stays that way this weekend. Today, we are happy to welcome Evie Amato, who is here from Faith and Family Hospice, who's going to talk to us about hospice myths and misunderstandings and the difference between hospice and palliative care. Evie is a board certified music therapist and has been working in hospice care for over a decade. Yes, and we're very happy to have her here. And I'm going to hand it over to Evie in just 1 second. Just a reminder, as always, that Walpole Media is here filming us today. If you have a question, just raise your hand and Evie will bring the microphone over to you so you can be heard, or she'll repeat the question for you. Thank you.
Thank you so much, Debbie. And thank you, everybody, for coming in today. As Debbie said, on this gorgeous day, I know I'm competing with the sun and this beautiful breeze. And I hope that we can have a little bit of a good time here today. I know it's not the most exciting topic, but it's definitely an important topic. And I have been working in the field of hospice and palliative care for almost 20 years now, actually, which is crazy to even say that out loud. But I have had the privilege of being with so many different people who have been facing the end of life journey. And even though I've been in the field for so long and hospice has been around now for a good amount of years, there still exists a lot of questions, understandably so, a lot of misconceptions, and just curiosities about what exactly it is, who is eligible, when someone can access it. And in the recent years of palliative care coming on the scene, things get even a little bit more confusing, as you can imagine. The good news is I think that in general, our government and our society here in the United States has been more engaged and receptive of understanding the wishes of patients if they're faced with a life-limiting illness. We are getting to the point where we're more accepting of, not completely the medical model that maybe has been pushed for so long. And so more options and awareness and education exist for those of us who are facing that journey, or those of us who have loved ones who are. And, none of us will escape this. And so it's really great that all of you are here today to find out more information or to share your story. I'm sure that some of you here have been affected by someone with a life-limiting illness, if not yourself. So this is certainly an informal discussion. I want to talk and guide us through these bullet points, but it's also an opportunity to really have a back and forth conversation and for you to ask any questions that you might have, or to maybe even bring up a scenario that has occurred and want to receive some guidance. Yes. I do. I think a few people just walked in. Yes, ma'am. No worries. No worries whatsoever. I'm so happy you're here. Would you like one? Oops. Sorry. I don't know where she... Would you like one of these, ma'am? At your seat. You're not staying long? Okay. No problem. Just grabbing the goods. Okay, so when you hear the H word, as I like to call it, when you hear the hospice word, what are some thoughts that come to mind? Care. Beautiful. Care. I love it. What else? Right. You can say, yeah. I'm supposed to bring the microphone to you, so
I hate to say, and they may be mistaken, but some people actually associate hospice with death.
Well, you're right, and that's a very important element to all of this, which we're going to talk about. And what about you, sir? You were saying something up front. That's okay. No, it was good. Being comfortable. Comfort care. Comfort care. You hit the nail on the head. Absolutely. Absolutely. Anything else? When you hear the word hospice or hospice care? Yeah.
Help. You know, that's a word that I think a lot of people don't think of, but I got about 15 years ago. I went to Arizona for 12 weeks to be with my sister for her in care. She was only 48. And the hospice was so wonderful. You know, I'm so far away, although she had a lot of friends out there that I met. But to have somebody come in who was such a help, and I think that's a big word, you know.
Thank you for sharing that. I'm sorry about your sister. Definitely. Anybody else? Well, everything that everybody said was true. And it's definitely a concept that probably evokes a lot of thoughts and questions and maybe stories and personal scenarios and maybe even fears and hopes. It's all of it. When I started doing the work of hospice, I recognized quickly that although it is the business many times of death and dying, that the service of hospice is focused on life and living. And we know that oftentimes we're faced with these uncertainties, and the goal is always individualized care and life and living. And so today I want to talk to you mainly about the difference between hospice as a service and palliative care, what they both mean, and then talk a little bit about some misconceptions about both services and answer any questions that you may have. And so we can just get started, because much of what you all shared about hospice, we're going to start with hospice. Much of what you all shared is on this page. And as I said, you hit the nail on the head. So when you think of hospice, I always like to explain it in two ways to people. There's the practical definition or description, which it's basically just a Medicare benefit that is available to anyone who is faced with a life-limiting illness. Now it gets a little more complex than that, because what's life-limiting mean? But in all, sort of its simplest form, it's a Medicare benefit that is available to people. Now, Medicare was the governing agency who in the United States designed the hospice benefit, but it is not only covered by Medicare, it's also covered by Medicaid or Mass Health and pretty much every private insurance that I've ever come in contact with. And most hospices also take on patients who maybe are uninsured or have no ability or coverage. That's rare, but that does happen, and I have never seen a situation where someone was denied hospice care. So it's a Medicare benefit, but then secondarily, it's a choice. It's a philosophy of care. So it is not something that should ever be pushed on someone or forced upon someone, and it's not something that you should ever feel like is pushed on you, because at the end of the day, you are driving the bus in terms of your care and your wishes. And so hospice is one philosophy of end-of-life care. Now, as I said in the beginning, many people this day and age are more comfortable and accepting when it comes to talking about end-of-life issues, and they're more aware of alternative ways of being cared for and not just going to the hospital, at the end or when things might look like they're facing the end. But I want you to kind of keep that in your head, that hospice is a Medicare benefit and it's a philosophy of comfort care. So we're going to expand on that a little bit. So, as I said, it's not for everybody right now. It is only for people who are deemed to have a life-limiting illness. And Medicare defines a life-limiting illness as anybody who has about 6 months or less to live if the disease runs its natural course. So those words are really important because I think, unfortunately, when they designed hospice, they had to come up with a metric of who is eligible, right? And so it's not going to be available for everybody because it is specialized care when someone is nearing end of life. So, but they had to put a metric on it. So what was the metric they used? 6 months or less. Now that is very hard to determine if someone has 6 months or less, especially based on different diseases. So many people, when they hear the word hospice, think of cancer because in its inception, most patients who received hospice care had a diagnosis of cancer or AIDS, HIV/AIDS. It was very popular during the whole AIDS crisis. But now, right, in this era, we are looking at people with all sorts of disease criteria. So not just cancer, but many folks with end stage other things, right? Cardiac disease, kidney disease, lung disease, stroke, right? A lot of neurologic diseases these days. Alzheimer's and dementia is almost replacing cancer as the most common end stage disease that we see in hospice. And that's because a lot of people live for a long time with those illnesses, and hospice can be a really, really big help, not just to the patient, but also to the family and the caregiving system. But because we have this metric of 6 months or less, this is the kind of the population that's eligible for hospice. And so you might be thinking, well, how do I know when, someone is eligible? It has to be decided by 2 physicians. They have to look at the whole scenario, look at the whole situation. Oftentimes, this is the patient's primary care physician that has a good long relationship with the person, and maybe also the physician in the hospital. Oftentimes, there's a hospitalization or different phases of decline that might happen with somebody's age and illness, right? So hopefully all of this information is here to help you, but you should never feel like alone in this conversation because your physicians, your care team, or those of your loved ones should also be thinking about the future and what might be coming and your care options, right? But that's what we look at with hospice. And so the lady in the blue in the back who was saying, oftentimes we think of hospice and relate it to dying. It's true, right? It's true because the care is specialized for people who are nearing end of life, who have that 6 month or less prognosis. And Medicare gives us this whole booklet of different disease criteria and different things like a checklist. Okay, is there weight loss? Is there, infection? Has there been recent hospitalizations? all these different things based on the disease to know when that may likely happen. Now, it's definitely an art, not a science, the art of prognosis. And physicians will tell you that all the time. And sometimes they wait a little too long to refer someone to hospice, because most of the time we want to help prolong someone's life if we can, if that is the goal, and if the person can be comfortable and have a good quality of life, and the life can be prolonged, then most of our physicians that we know, they go to school to save someone, to try to cure something, to try to extend life. And it's always a balance for them to know, is it time to introduce the concept of hospice? And so it's a good idea for all of us who are in control of our own journeys to know that there's always an option to say, I don't want to go to the hospital anymore. I don't want to receive this treatment. Or what are the benefits and burdens of going back to the hospital this time? What are the benefits and burdens of another surgery, or of, XYZ that might be on the table for treatment? But hopefully, I think a lot of physicians are becoming more comfortable with the topic for sure. Which brings me to the next point that people often say, okay, so I come onto hospice. I was given this approximate prognosis of potentially 6 months or less if things continue as they are. What happens at the end of 6 months? Do I get kicked off of hospice? I didn't die, right? And that's not true, right? Because we know, as I said before, this is an art. This is a best guess. This is a let's give this person all of this care now. Let's not wait until the final days. And oftentimes that's very hard to do. And sometimes you guys probably know people that have been on hospice and they've only been on hospice for like 3 days, right? And that's because, well, I can't say for sure, but there's a lot of reasons why that might be. It could be the person themselves wasn't ready and did not want that care until those final days. It could be that they were involved in some like life-sustaining treatment until those final, and things got worse really quickly. We don't know, we can't predict it, but we want to try to make sure that they have the support for as many days as they can. And so if 6 months comes and goes, the hospice team is responsible for basically like filling out a report to Medicare and saying this person is still, experiencing this decline in health and still qualifies for hospice. And actually somebody can have hospice for an unlimited period of days. When you first sign on to hospice, you come on for, it's like a 90-day period, and then you have a reevaluation at 90 days, and then every 60 days after that, the nurse fills out a report based on how the care is going and how the person is, how the trajectory is going. Sometimes people have a slow decline and steady decline, and other times it's quick, and other times they get better. And we do see, more frequently than you would think, that hospice comes on board. Sometimes, we relook at all the medications and we talk to the patient. Is everything necessary? What are their goals? We help them with their plan of care, and then they kind of rebound and they start improving for a while. And we have had patients graduate from hospice only to maybe come back, down the line if it's needed. So it's a very flexible benefit in that it's not like hard and fast at that 6 months and then that's it, but you can requalify and qualify for, you can keep going on it for years as long as there's that like slow decline. Hospice treats the symptoms of the disease, but not the disease itself. So it's a Medicare benefit. It's a philosophy of care focused on comfort. It's not focused on curing the disease anymore. And most of the time that's because the disease is likely not curable. So folks with end-stage Alzheimer's or dementia, we know there's nothing that we can do to reverse, at the end stages. So the goals are comfort and quality of life, or certain cancers where maybe treatments have been exhausted, right? But that doesn't mean that the patient receives like less care or less medication or less treatment. We're going to treat the symptoms, making that person more comfortable. So people always ask, well, does this mean that I have to, like if I have an infection, I'm not going to get antibiotics? No, that doesn't mean that, because giving that person the antibiotics for a UTI or some type of infection will probably make them more comfortable. And it's not going to do anything to alter or cure the underlying disease. So it's all sorts of ways of delivering comfort, physical, emotional, spiritual, just not looking at that plan of care of curing the underlying disease, right? That's a big difference between hospice and then palliative. So we're going to talk about that in a second. Hospice can be provided wherever the patient calls home. This could be home itself. It could be in a nursing facility or assisted living. It could be oftentimes, if it's very end of life, many hospitals partner with hospices, so they have like both teams with the patient. It could be on the side of the road under the bridge if that's where the patient is, which we've had that before. The other thing with hospice is that it's more of a comprehensive group of experts in end-of-life care that you have access to 24 hours a day. They're not going to be sitting by the bedside 24 hours a day, although I wish we could, but they'll be making intermittent visits to wherever the patient is. And oftentimes, if there's a decline or a symptom comes up, it's most likely daily visits. And you have access to this care team 24 hours a day on call. Can I get, you got it? Mm-hmm. Oh, you do, okay. And oftentimes the circle of hospice care is the hospice physician, the hospice nurse, hospice aide, hospice social worker, hospice chaplain, hospice volunteer, and then sometimes extra stuff too. So I'm a music therapist, and so that's my specialty. And I've used music to help with all sorts of goals in hospice and end-of-life care. Sometimes it's with the patient, sometimes it's with the caregiver, sometimes it's for pain relief or anxiety relief or comfort, sometimes it's for reminiscence and writing a song and leaving a legacy, closure, bringing back good memories, all sorts of things that music can do. That's a conversation for another day. But you have that whole care team. We also at Faith and Family Hospice, besides music therapy, because that's not a typically reimbursed by Medicare, but we also have Reiki practitioners and pet therapy as well, because our goal really is to meet the needs of the patients and families in all different ways that we can. And this doesn't mean that every patient gets all of this, like they can access all of this stuff, but sometimes they pick and choose what they need at different points in their care. It might be that we're all in there, like all together working as a team. It could be that they just want the nurse and the aide in the beginning, or maybe just the nurse. And then as things change, they kind of want others to come in and help with different things. But you have access to like all those services and 24-hour on-call support with anything that you need. The emphasis is on, maybe it's not on quantity of life at this point, but it's certainly on quality of life. And that is defined by whatever the patient and family says it is, because my definition of quality of life might look very different to another person's, right? And then obviously in hospice, the support extends beyond the patient. It goes to the family during hospice care and even beyond into bereavement and grief support for 13 months or really as needed. Okay, so I'm going to open it up to questions in a little while, but I just want to contrast, because now that it's sort of fresh, I want to contrast what palliative care is while we're here. So people get confused, rightly so, because palliative care is also known as comfort care. So what the heck? And sometimes it acts as a transition to hospice. Sometimes it acts as a bridge to hospice. That's only if the patient is experiencing a lot of decline and they're heading towards that 6 months or less prognosis. Then oftentimes people might access palliative care first as like a way into shifting their goals to more of a comfort focus. And then they really might be hospice eligible even if they're on palliative care, but they're sort of like going that route, and then they might transition to hospice if they choose. But the biggest difference between hospice and palliative care is that if you access palliative care, you do not need to have a prognosis of 6 months or less as determined by 2 physicians. You can be usually the person has a serious or life-limiting illness that's causing some discomfort or pain, and the disease may or may not be curable, but you're not necessarily at that end stage. So you can which is great, because you can access the philosophy of comfort and quality of life and start to have conversations with a palliative care team about what maybe different treatment options look like. And you may be at the point in your care where you are getting aggressive treatments for a disease, and you can still access palliative care physicians who help to work alongside that treatment team and say, well, what are the benefits and the burdens of X, Y, and Z? And, what are your goals? Now, most hospitals have a palliative care team that can be brought in as like a specialty team to work with the treatment team and say, okay, this person might have, years to live, but let's just say the renal disease does not improve, or, if the cancer or whatever it is they're looking at, if things continue, they can be brought in to say, well, let's have that conversation now. We're not stopping any treatment. We're not saying, there's the cure isn't going to work, but let's just have the conversation so that if and when a time comes where you don't want this treatment anymore or things drastically change in your health, let's get everybody on the same page. Let's fill out your advance directives. Let's talk to your family, right? And so that's really important, because the medical model in many situations is just especially if the conversations are not had, is just to treat all the way up and, until the end. And sometimes that's not what we want, right? So that's why we have palliative care. Palliative care is also covered, covered by most insurances. Like I said, it can start much sooner than hospice and be provided alongside curable treatments. The philosophy, though, is very similar to hospice, and it's looking at the whole patient. Someone might be diagnosed with end-stage cancer, and the palliative team might come in and say, what are your goals? And the person might say, well, I want to live as long as I can up until I can, enjoy my favorite meals up until I can have enough consciousness to be myself and talk to my family and enjoy my life. But if I can't have football, or if I can't have, my sandwiches, or if I can't have, enjoy these things, then that's not quality of life to me. Okay, these are all important things, but we're not just looking at pain. We're not just looking at quantity of life. We're asking the whole person, what does quality of life look like to you? And that's very similar of the conversations in hospice. And they assist with difficult decisions about the future, which we talked about. The palliative care team is many times in the hospital, but there are definitely palliative care physicians and nurse practitioners that are sprouting up in primary care offices and places like that, and can be called in for a consult if that's needed. And so sometimes you could have palliative care visits at home, maybe by that nurse or nurse practitioner, or maybe a social worker, but it's usually as needed, right? It's not going to be that whole circle of hospice care that's just with you on your journey. It's sort of, they're consulting on palliative care, and they're coming in when they need to come in. And as I said before, it may or may not act as a bridge to hospice. People can access palliative care for pain in the hospital and still live many, many years, because it doesn't indicate that end stage necessarily. But sometimes it also does. So it gets a little confusing. But I'm going to stop here and just ask if there's any questions at this point based on what we've discussed, because I know that they're very similar, but they're different also. So I'll take questions. Yes. Here.
Did they change actually the eligibility for hospice? Because I recall when I brought hospice in for my mother, it was back in 2013. And I mean, she was very alert, and she just had a cardiac problem and she was in assisted living anyway, so she had good care. But I recall that I thought that it was a year or less. Did they change that?
Not that I'm aware of. I think it's always been that. But that's okay. But as I said, it's very hard to predict. And so they might have said something to you like, we see your mom, maybe going beyond the 6 months, but we're not sure. And sometimes patients come on when they've had like a hospitalization, and it could almost go either way. Like it could be a decline, or they could, kind of stabilize for a little while. So they might have said something like that. They've been using the 1 year terminology more for palliative if someone's going towards that end stage. But I think with hospice, it's always been that 6 months, but it's just, they never know for sure, so yeah. It's tricky. And I think some people don't like to say it out loud to the family, like, so there are certain healthcare professionals, we try to sugarcoat things. I mean, I don't want to do that, but I'm also not a physician, and the physicians are really the ones that should say. Sometimes the nurses give their best guesses too, but there's a study there's multiple studies that have been done that say that the longer the patient knows their primary care physician, the more inaccurate the physician is going to be on their prognosis by like a long shot, like by months. And sometimes, and they assume that that's because of the caring relationship that sometimes our physicians develop with us, and we don't want to, sometimes they don't see what's happening or don't want to see. Now I'm making generalizations, but I think it's a hard topic, and so sometimes people don't get the most accurate information right at the get-go too. Did she live for a year? Oh, so she came on and she lived past a year onto hospice. Okay. Well, that's good. That's nice. So she had all that support. That's a good one. I think most of us would agree with that. Yep. Supposed to give this to you.
Not to be on a really depressive note, but is it the ability of hospice team that certain people other than physicians can pronounce death?
Yes, so nurses can also, but they need an order from the doctor, but usually they can do that over the phone, and the doctor has to sign the death certificate, but they don't have to be there. It can be like an order given by the nurse. But that's a great question. It's a real life question. Yeah.
So you had said something about if someone's on hospice, they review their health after 90 days.
Yes.
And then they can continue as long as
They're called certification periods or benefit periods, and so there's 2 90-day periods.
okay.
And the family may not be aware that there's this like whole recertification process going on, because sometimes it happens behind the scenes that the hospice that's coming in to care for the patient, it's their job to document the decline or the improvement of the person. But we look for we continue to kind of look for the decline so that we can continue to provide the support as long as that patient is actually showing signs of decline. So they have to fill out a whole recertification assessment, and then that goes to the hospice physician, and then they have to continue to agree that the care is still warranted. So it's 90 days, and then it's, the rules are that they can have unlimited 60-day periods of hospice as long as decline is still being noted. Does that answer? Yeah. So sometimes it can go on for some time because that's just, the way the patient's progressing, or, things could happen sooner. We don't know. What else? What other questions? Could be anything at all on this topic. Yeah.
So much of what you're saying sounds like it could be palliative.
Yes.
Now, that's the part. See, I'm very familiar with hospice. It's the palliative that's kind of confusing to me. So, it sounds like the lady that lived a year she could have been in palliative from the way it sounded.
She was in assisted living, so hospice came in, but not like every day. Came a couple of times a week, and then she had nurses there around the clock anyway.
So maybe the assisted living could be considered palliative?
Yeah, I think they were working sort of like in a partnership.
Right.
And it was very good. I mean, her mind was fine, though. She never, like I said, she was bright and alert until she went to sleep and didn't wake up. So that was good for all of us.
So the biggest difference is really the 6-month or less prognosis, or, the 6-month or less qualification. And it gets fuzzy because sometimes you could be eligible for hospice and palliative care at the same time, but just because you're eligible for palliative care may not make you eligible for hospice. You have to really show these end stage qualifications to have hospice. And so for this lady's mom, she must have shown enough decline when she was eligible for hospice for the doctors to say it's likely that in 6 months she could pass. Like, it's not unlikely that that might happen. And that's sort of how they look at it. It's that like approximated guess. They're making this decision to say, would I be surprised in 6 months if this person continues to decline and maybe reaches end of life? And if they're not surprised, then that is one of the things that would qualify them for hospice. Yes, Jane in the back.
I just want to make a comment too. Hi, I'm Jane with Faith and Family. I'm Evie's colleague. So with palliative care, oops, sorry. So I'm Jane with Faith and Family Hospice. I'm Evie's colleague. So with palliative care also, it is the 1 year prognosis, but it's only a consultation by like a nurse practitioner or a provider that comes in once a month. You don't get all of that supportive care services like you do with hospice. And, you know, the nurse, the chaplain, the social worker, physical, music therapist, pet therapy, Reiki, all of that goes with hospice. With palliative care, it's just the monthly-ish consultation. And with palliative care, somebody might be going still to get aggressive treatment, where hospice is truly focused on comfort. So those are kind of the two big differences. Hopefully that clarifies it a little bit. Yeah.
Does that help a bit? Yes, it does. Okay. The philosophies of the care are very similar, but the eligibility is different, and also what you receive is different.
Can you speak also to the sort of different locations? Because I've seen hospice at home, I've seen it in assisted living, I've seen it in nursing homes, and I've seen it in hospice houses and hospitals. So different locations.
Yeah, so people can receive hospice wherever they're residing. So that many times, as you were saying, it's a really good partnership, because if the person is in a nursing home or an assisted living facility or a hospital, and then they get hospice, it's not like the hospice comes in and just takes over, but we really act as a team. And so they still receive the care from the nurses and the whole care team at the nursing home or the assisted living, but now they have sort of experts in either end of life or maybe types of symptom management with different diseases, and we sort of all act in collaboration. That's really hospice care at its best in a facility where you have the support of both teams. Obviously at home, it's usually just the hospice coming in with either family support or maybe private caregivers. And then there are hospice residences as well, and some of them offer different types of care. Some of them are more like acute care settings, and some of them are more residential. Those are mostly private pay, where someone might opt into a hospice house, and it's like a beautiful setting, and they can have hospice in that residential building. And also in hospitals. So as I said, I think before, usually the hospital, if the patient can't go home or can't go back to maybe their previous care setting and they're getting their symptoms under control at the hospital, but maybe things take a turn and it looks like they're nearing end of life in the hospital, most hospitals now have like a hospice like a hospice team, either on site that just comes to that patient's room and delivers all those services there. So music therapy would be there, and the social work and the spiritual support and all that would be there. And so they have sort of that coming in at the end of life in the hospital. But it can be anywhere. It's really meant to be wherever the person is. Yes.
A financial question. Correct me if I'm wrong. The hospice is covered by Medicare.
It
Yes.
Yep.
Okay.
If the patient has Medicare,
Okay.
then that's the primary coverage.
Okay. And when you go to the palliative care, is there any insurance that does not cover it, or does that vary dependent upon the individual?
I don't know as much. I'm not 100% certain on that answer as much as with the hospice, but I do know that it's covered by palliative care is covered by most insurances. I guess it definitely would depend on that patient's particular insurance, but it is covered most of the time. Hospice, if the patient has Medicare, hospice would primarily cover. If the patient has Medicare, Medicare would cover hospice primarily. If they don't have Medicare, if they're straight Medicaid, that would cover it. Or if they're younger than 65, they don't have private insurance, that would cover hospice as well. Just depends on what they have. Yeah. There's another question. Oh, I'm sorry.
When we were talking about insurance, I used to be a long-term care nurse. Of course, that was a while ago, but the Medicare end of it is a lot more straightforward. I mean, it's pretty cut and dried. The little extras with Reiki and things like that, it's kind of like just your insurance now. Whatever you've got, Tufts, Medex, Core, Bronze, whatever. It's kind of the same as like any other insurance with like what you have now. Private pay, well, that's private pay. So the main thing is the Medicare end of it, and then you have to look at your own individual policy and see what you have to read the fine print in it because it changes every year.
Thank you for your guidance. The only other thing I will say on that is it can get tricky if a patient is in. I'm sorry. Let me get to you. I missed you. How did I miss you?
People often miss me.
No.
Go ahead and tell them.
I had a question. If you've seen what I'm going to describe a lot or very seldom or whatever. Persons in the hospital, unconscious. It's estimated that within 12 hours they will be dead. Okay, that's what the professional expert. Okay. In this case, it's pancreatic cancer. Now, the family requests that she be taken home so she can die in her own bed. And they do that. They call it hospice care. And within 4 hours, the person is deceased. Does that happen very often? At least in your experience, obviously.
Let me ask you this: was the patient comfortable? Did the family think the decision?
Yeah, they
good
thought
in
it was
the
all
end?
right. Okay, but but they were told right up front that the person was not going to make it past 12 hours. And the person made it about 4 hours.
So they were correct in their assumption.
Yeah.
Just
I mean,
they
the
were.
person
Yeah.
was gone.
Yeah.
So that's what I didn't.
Just wondering if I see
If that's something that happens often. Or
that people go home for the final hours, or that what's the question?
The question is, under not palliative, hospice care, because that's what they called it, that someone would be removed from the hospital by ambulance, brought home, and before the sun set, they're gone. I mean, they're pronounced dead right on the spot.
So we've definitely seen that happen. I've worked with many patients and families who had a similar situation where it was the patient's wish and the family's wish, sometimes one or the other, sometimes both, that they go back home to die at home. Sometimes as if we were a hospice care team contracting with that hospital and we knew it was going to be hours, we might say we might just really relay to the family, it might be it might kind of be a rough transition. if the patient's comfortable here, even though the wish is to get home, trying to shift the mindset to say that, you know, the patient is comfortable where they're at, because the other side of the coin is that we have seen patients who are steadfast on getting home and could not, maybe they don't make it because they get in the ambulance and that's where they take their final breath also. So it's a very tricky thing because nobody knows, and if it's that close, it's tricky, but it's great that the person did make it to where they wanted to be. The family did. Yeah, and at that stage of the game, it's another tricky thing because sometimes it's the patient making those decisions if they're coherent until the end, but oftentimes it is the family or the healthcare proxy. And that's why it's really important that the conversations happen up front and different scenarios are talked about so that if the patient is still conscious enough, if and when they are, and they might say, this is what I want, this is not what I want. But at the end of the day, it's hard to predict every set of circumstances. And it is nice that many times we have patients or families that request that the patient go home for their last hours, and they do make it there. And it's, sometimes we can't consult with the patient to say, you know, oh, you're home, because they might be so out of it at that point. But it is a sense of comfort to the families sometimes to be in that familiar environment. And then there's families who would prefer not to have that happen at home. It's all very individualized, but that's definitely a scenario that is, has happened before and will happen again. Yeah.
And again, I am a retired nurse, so I never worked in any hospice, and I appreciate and compliment anyone that can do it, because it wasn't something I could do. But I think with the current state of healthcare now, that people that are at end of life, unless they have COVID, they don't want them in the hospital. I hate to say it, but so I imagine hospice is probably, and palliative care is coming up a lot more frequently now than in the past.
Really good point. Yeah, I think there's definitely truth to that. It depends. It depends on sometimes the hospitals are, aware that they need the bed for another situation, but sometimes the doctors and the nurses on the floor are like fighting to keep that patient there. That patient's comfortable, and we're all trying to navigate it the best that we can. And ultimately, at the end of the day, it's that patient's choice. And if the patient's not able to make that choice, then it goes to that healthcare proxy that's designated. And it's tricky if there's big families involved and they all have different opinions and, feel differently on what their loved one might want. At the end of the day, the hospice team, the hospital team will defer to that one healthcare proxy, whether that's good or, maybe, I don't know, not agreed upon by the rest of the family, but that's what they should do, and that's how we would operate as well.
Can I make a comment about the hospital too? Sometimes with respect to the hospital, you go to the hospital, the doctors are looking to, prolong your life, to save your life, and
to treat.
And when somebody goes on hospice in the final days or hours in a hospital, the hospital staff sometimes are not experts in how to treat certain symptoms, and they look for the expertise of the hospice nurse and the hospice docs to make appropriate recommendations for symptom management. So that's why a lot of times it's important too. Some families will say, oh, well, my loved one's going to pass within the next, 6 to 8 hours, day or two. Why put them on hospice? And for one, it's to help support the family, the patient, but also so they get appropriate recommendations for symptom management, whether it's
acute pain, respiratory distress, or something, like a terminal extubation, which we've done in the past as well. And in situations like that, we have our whole care team come in, from music therapist, social worker, chaplain, nurse, and any other supports that need to be there. So, and in the hospital, if somebody is on hospice in their final days and they pass in the hospital, it's a benefit for the hospital because it doesn't affect their mortality rate as well. So from a business standpoint, you have that, but you really can have all of the supports for the family and the patient when they're in the hospital on hospice. So I just wanted to add that.
That's a really good point, because I have met with families when it's so close to the end and they were like, well, why bring in hospice now? And those are some of the benefits to it. And then also for the bereavement, that extends beyond for the family members, for sure. This has been a great conversation. What other questions or comments, if any?
You did a good job.
Oh, thank you.
You did a really good job.
It's not an easy topic.
No, it's not. And it's the way you present yourself.
Thank you.
It's where everybody needs to have this
Appreciate that.
information.
Definitely. Thank you for saying that. I'm going to stay with you guys today. I did include on the bottom of this page some common myths and misconceptions, which I think we talked about a little bit. Certain things. It's a hard decision to have to make to access hospice, but it's also one that could mean the difference between that, quality of life and, your choice and living out your days in the way that you want. So there are some interesting things. Like, I think a lot of times people think you need to have a DNR signed and all those advanced directives to access hospice. You don't. Certainly, we will have that conversation with people, but we've had patients on hospice who, for whatever reason, and it doesn't necessarily matter because it's their decision, but that they decide to remain a full code. And there are some hospices that I've worked with that have a hard time accepting that and with that, but most of the time it's not a deterrent to coming on to to hospice, just so you know, and that you can still visit with your primary care physician. You don't lose that. There's a hospice doctor that is on the team that can consult, but that your primary care physician actually remains the same, and that's the person who would continue to prescribe and, be consulted with by our team. So that all stays the same as well. And last but not least, because I think the biggest thing when people think of hospice is, is like this feeling of giving up and relinquishing control and choosing death. And so although it's choosing comfort and it's choosing to stop that mindset of potentially curing the illness, there's been a couple of studies done that actually show that people who access hospice live longer than those who don't access it. On average, about 30 days longer than those who don't. And with palliative care, also, that life is actually extended. So even though we feel like, well, it's not extended, they're going on hospice, it actually is. People live a little bit longer when they access this type of care. So something to know and to leave on that note. And I did put our number down, but I'll stay here for a bit if there's any other questions or thoughts. I hope this clarified things a little bit. If something comes up, you could always call us. My name is Evie. I'm happy to talk with you. I'm a music therapist, but I do all these other things too. So community support and education, and I'm happy to help with anything that I can. Thank you guys so much. Appreciate it. Thank you.